have a lot of ground to cover. So I appreciate everybody getting themselves together and here and on time and under budget. So with no further ado, I'd like to introduce Dr. Kaplan.
So my name is Jay Kaplan. I'm immediate past president of ACEP, flanked on my left by Steve Anderson, who's also a member of the ACEP board. I wanted to just welcome everyone. Dean Wilkerson, who's our executive director, will be here around the noontime hour to give a little bit more of an extensive welcome. This is very exciting for us. We want to welcome you on behalf of the ACEP board. Brings me back to my days in 1971, 71 to 75, when I was a medical student and rode the Bridge Over Troubled Waters free medical van all around Boston. When I was president of ACEP, there were some social medicine issues that were very important to me that caused some controversy and that were nevertheless needed to be said and needed to be brought out. This is very exciting because this is our opportunity to expand and develop concept and a happening and to spread it further throughout emergency medicine. So I want to welcome everyone. We are now 1 year in this building as of yesterday, and we work very hard on making it a place that emergency medicine and emergency physicians could be proud of. I suspect it's many of y'all's first time here in this building. So I've talked to Lauren and we are arranging tours. The exact time it's to be determined, but will probably be tomorrow morning since we start at 8:30. We'll do our tour at 8 o'clock here tomorrow morning, but Lauren will finalize that a little bit later on because we'd like to show you everything that this building is. Okay, I'm going to turn it over real briefly to Steve.
Thank you very much, Jay. For less than 1 minute, I want to thank everybody else for showing up. For those of us that are tired of the Band-Aid and the revolving back door that just brings people back, you really are at the paradigm right now of impacting patient care. But I want to take 1 minute, and I really want to thank the fact that ACEP, the Levitt Center, the Robert Wood Johnson Center, and sitting on the board of directors of the EMF, Emergency Medicine Foundation, all came together to help sponsor and put together this forum. So, welcome.
Well, good morning, everybody, and welcome to Inventing Social Emergency Medicine, which is just as it sounds. It's a process beginning probably 40, 50 years ago at the birth of emergency medicine, when people staffing emergency departments immediately noticed that socioeconomic factors could not be ignored in the provision of clinical care. And when we founded the Levitt Center about 10 years ago, we looked at the 5 or 6 authors who were publishing the papers that we wished that we'd published and asked them to join us as our scientific advisory committee. Some of those people are present today. And in the 10 years intervening, the literature on social context and emergency care has just mushroomed and really necessitating us to get together and define the intellectual underpinnings of this burgeoning field. You know, it's a little difficult with all the suffering of our brothers and sisters to the east and south of us right now for us to gather, you know, in this room and cogitate. But I guess I would, and we want to keep them in our minds. I guess I would say also that, you know, people are suffering from an earthquake in Mexico and from flooding in India and Bangladesh, and really these episodes of waves of human suffering don't abate. So there's an urgency to this topic that we have to address today, and I think it's probably best for us just to forge ahead and do it, keeping, you know, what's going on around us in mind. I want to remark before sort of setting the stage on what a remarkable diversity of thought we have in this room today. We have students, residents, fellows, junior faculty, mid-career people, and we have some people who were present at the birth of emergency medicine. It's really a remarkable breadth of experience and ideas, and I think it's not unprecedented by any means, but I think it's a wonderful harbinger of the future of social emergency medicine that we're able to gather people from such a wide range of experience. We have academics, we have people from struggling safety net hospitals, we have people from community medical centers, unaffiliated with academics. We have people who overcame, unimaginable obstacles to get here, and we have people here who were delivered, here by a lifetime of privilege. So it's really impressive to me to see what a magnificent assemblage of individuals comprise this group, and I hope that from that diversity of thought arises a creative spark that will feed this field for many years to come. Let's see. A couple of I've been asked a couple of times how the structure of this conference evolved, and if you'll allow me to indulge in a little bit of history, in 1987, I attended a conference at the Kaiser Family Foundation in Menlo Park, California, that was an invitational consensus conference that started with 6 invited papers and 2 commentaries on each paper, and proceeded with discussion about the papers and resulted in this book that was published in 1989 by the Kaiser Family Foundation, now out of print, but still very dear to me. That conference had a huge effect on me. The purpose of the conference was to look at socioeconomic status and health 20 years in. What do we know? What do we need to know? And I was amazed at the sophistication of the economic analyses. Rereading it over the last couple of days, I'm amazed at how little we knew about pathophysiology. I mean, we've redefined entire fields from the cancer epidemiology chapters, right? They were hinting at markers for cancer at that time, and now, of course, they're commonplace. But the economic analyses and the input from the sociologists, particularly Saul Levine and others, is really penetrating and I think bears re-examination. So I don't know how to get this out into people's hands, but it's important reading. So when we founded the Levitt Center, I knew that a conference was in our future, and I always sort of promised myself that since that conference had such an influence on my own development and my own thinking, and I just thought it was so well executed, to have hard commitment of people's thought on paper to bounce ideas against. I just thought that was really well done, and so I sort of promised myself that if ever we were to hold a conference in Social EM, that it would have that format. And so far, reading the materials, I am not, I'm just shocked at the quality and how I think the discussion will go today. And then, collaborating with the American College of Emergency Physicians and the Emergency Medicine Foundation to present this idea to the Robert Wood Johnson Foundation and to then get their support to bring us all together here, it's, just kind of beyond my dreams. So you guys are here to make this manifest, and I just want to express my appreciation to all of you for achieving this. There are some just two business items, kind of. One of them is that the last session tomorrow, that will go from, I think, maybe 10:30 to 1 o'clock, is a summation session, but it's also an attempt at a modified Delphi process to arrive at the most important, what this body will approve or approve as the most important or pressing questions from a research standpoint for the future of social emergency medicine. So over the next 2 days, what we're going to ask of all of those involved is to formulate 2 research questions, answerable questions, and submit them to Lauren or Jana at their email addresses, which are both they'll be up on PowerPoints. They're also in the table of contents. Oh, they're also in the, and on the agenda at the back. And submit them to them by email. They're going to mount those into a program that allows us to vote on the ideas. And so over the course of the 2 days, I hope we're going to send out the link for this program, Dot Storming it's called, and you'll read through the questions and vote for those that you think are the most important. And what we hope will arise out of this process is a discrete list of sort of ratified by 50 thought leaders in social emergency medicine of the most pressing questions that then, grant writers and authors can point to as, I'm not the only one who thinks this is an important question. This is a question that's been proposed by the colloquium at Inventing Social Emergency Medicine. It doesn't carry the weight of a study section, but it's at least some degree of ratification. We hope to have a list that then can guide us as investigators and also support our grant writing. I would say that you can start voting as soon as today. I mean, obviously the questions will change over the next 2 days, so you may miss the opportunity to vote on, a question that you like better. Can you change your vote? Do you know? We don't have enough experience with dot storming to know if you can change your vote. Because I've been advised that the process can actually take longer than we had allocated to it, I would say, if you want to wait till tomorrow midday to do your voting, that's great. Just try to stay up to date on the questions as they come in, so that you don't have to read through all 100 of them tomorrow morning. The other thing that I wanted to remind people of is that our publication plan is as yet undefined. We're hoping to get this published as a journal supplement, and if not, as a monograph, and if not that, then as a web document. So one way or another, this is going to get disseminated. What I want to remind you of is that it's not a fixed document with these 6 papers and 12 commentaries. By the way, you might say, well, I only read 5 papers, but paper number 6 isn't written yet. It's the summation of the play of the game. So it doesn't have to be fixed at that number. So if you have a reflection or an inspiration that arises out of these days, and you want to draft it into an essay or a statement or a paper, I would say go for it, and we'll try to get it included in the package for publication. In the Kaiser book, it's really a discussion back and forth among investigators and scholars. There are people who appear 4 or 5 times responding back to things that other people are responding to. So I think that a conversation in print could be very inspiring. So I will encourage you to take careful notes, listen carefully for the next day and a half, and think about whether you want to try to prepare some kind of a response or a riff, or go off in a direction that's inspired by what you learned here. I already expressed my appreciation to ACEP and EMF and RWJ, but there are individuals at each one of those organizations that need to be identified and thanked individually. Sandy and Cynthia at ACEP, were the engines of this operation at the very start. It never could have gotten off the ground without the vigorous grant seeking by Sandy Schneider and Cynthia Singh. So I'm very grateful to them for that. At RWJ, our program officers, Emmy and the Vice President John Lumpkin, who's an emergency physician who wished he could be here but wasn't available to come, were instrumental in shaping many aspects of this conference. Ann Cummings at the Levitt Center, our COO and Associate Director. I don't know if you're in the room, but Ann, thank you very much for thank you. And lastly, Lauren and Jana at ASAP just really made this happen. There's no way it would have happened without you. So thank you so much. And I think that we're ready to launch. Our first paper is really a home run, in my opinion, by Doctors Goldfrank and Fahimi. Together, they wrote this paper that, as a team, they have this parallax vision that allowed them to see social EM with such clarity. And the paper really, I think you'll agree, it addresses our preferred self-image as emergency providers and gives us all something to live up to. So I'm going to give the floor to Drs. Fahimi and Goldfrank, and then their commentators will have a few minutes to respond.
I think I have a couple of slides here. Okay, good. So this is, I think, the way I'd like to give a sense of probably what we mean by the paper we created. And John and I he was the student at NYU, and we talked about things like this for some time, and we just issues to the past and the present. So this is what probably people thought about medicine in a world in the 1920s. And Norman Rockwell placed us in this environment. The next slide, please. And next slide. And so the next slide is what I was taught by my grandparents about what life was about. And so we often talked, and my parents talked extensively about this. John said this is on his wall in his office, and lots of us use the thoughts of, Virchovian thoughts to design what we're doing or to think what's going to be rational. All of you have thought about this a great deal. Next slide. The idea about using art and medicine as an image by Picasso is that all of us in the room, when we look at each other, see different things from about each other, and all of us are really uncertain about the totality of the process. And that it's a picture of Maya, Picasso's Maya, mother and child, and really that it's one of these faces that looks in several different directions. It really gives one the sense that there have to be many people in a room to understand what the patient's story is. There has to be a capacity to listen. There has to be a capacity by many different types of people to listen. And so I think I wanted to set some of the philosophy to use the concepts that we all, I think, share in this paper that worked on. The idea that you have to have some values. People talk about being burned out, I would say. It's in vogue, I guess. I would say that being an emergency physician, you can always feel that you're succeeding because you're going to help someone every day, and you're going to find a new problem that no one else has ever seen. The question is what you do with it. So I'm really interested in caring for people. That's how I start. I think we try to say that as emergency medicine. I want to understand the problems that others really haven't thought about and are unwilling to address. And ultimately, where do these things come from? What are the roots? What's the trajectory in this process to finding out the needs of the most disenfranchised? The advantage of that is that probably the most enfranchised have similar problems, they express it differently. But everyone needs us to think better about these principles. We're not as general, maybe in this paper, as we'd like to, and I think that'll be a critical part of the discussion today about occupation, education, immigration, universality of care, things like that. We deal with things that maybe we feel we can work towards, but the big picture is what we've got to get to. And we only can do it with multidisciplinary teams that really are made up of everyone in the community as well as in the hospital, and in the outpatient department, wherever you'd like to look. But those are all different communities. They all have to be integrated. Next slide, please. Again, Picasso had a little bit more dramatic perspective, but we face every single day every person who's a failure in the public health system, a failure from society. They wouldn't have to come to us. If the world were good, we wouldn't have emergency departments. We'd have the kind of care that people need in the places they need that are the total well-being that they are entitled to. So everyone is an unsolved problem. Everyone needs an investigator. All of us are investigators. Some are remarkable, and others will be essential to being parts of teams. That some of the people that I can see across the room are people who've changed the vision of the world because they looked at something that others said was there and they couldn't see what to do, and they left things in terrible shape. And I think that several of you have NIH grants to look at problems that others never would have believed. So that for people to say they're burned out, and we can say that we started with Norman Rockwell, and now we have people who are able to do research on preventing homelessness or how to get care for people who everyone else is abandoned because they drink too much alcohol and come to emergency departments hundreds of times a year. We're organized effectively enough to generate critical leadership, recognize expertise, establish collaboration, and particularly, in my experience, it's population health as a department, and it could very well be every department that exists because all people share these burdens. Some have sheltered themselves from the social responsibilities that we are emphasizing, and have emphasized a simple biochemical physiologic model that obviously is demonstrably failure. Next slide, please. And although I used to use the slide, the part on the right, when I talked about the problems of deans understanding emergency medicine, when I tried to explain what Matisse meant, that the deans looked like nuns. They said they couldn't understand what we were doing. So people will say that they can't understand, as several of you have written in your commentaries, you can't understand what we're doing, and people are outside this image. And that's our responsibility to change the environment and change the understanding and the communication. And I think these cohesive, integrated relationships with our community, which are expansive, who are they? Where do they live? How do they live? What's their culture? What's their language? What are their needs? And this breadth of community that has to be established, because if you leave out one anthropologist or one sociologist or one lawyer from a community, or the police officer when you're trying to do a grant and understanding what they see, you're failing, because it's not going to work, because there'll be too many critics thereafter. They don't all have to agree, but they all have to share a common language. And the last slide. This is, Schopenhauer's a little depressive, but the point that he really emphasizes here is the task is not so much to see what no one has yet seen, but to think what no one has yet thought, or that which everyone sees. And that's what some of the most remarkable people whom I work and whom I read about and respect are doing. There's nothing that's impossible. That's just the confinement of a prison that doesn't allow you to participate. So these, I hope, will allow us to interpret what we've tried to write and express, and John has worked so hard effectively to do this.
Great, thank you. So with that overview, I'll introduce a little bit about our paper. Our goal in writing this paper was to cover a lot of ground, to cover the breadth of what we saw as social emergency medicine, but to do justice to all the important components. And I'll just quickly summarize, the points that we address, and then I'll pose some questions and perhaps we can have a discussion. We started off with the tremendous history that has kind of delivered us to where we are today, much of which is, before my time in medicine, I don't have an appreciation for. So things like EMTALA, which, provided an incredible shift in the way medicine and emergency medicine is practiced, really has been a landmark of modern emergency care. And I'm hopeful that the work that we're doing here can be the catalyst for another major shift in emergency medicine. We talk a little bit about emergency physicians and the importance of cultural competency, and in particular how that is something that we are good at and should continue to be really good at. Narrative competency, the ability to understand language and culture in ways that perhaps other physicians or other providers may not appreciate. We turned a little bit to the overview on the challenges to the practice of social emergency medicine, be that time, be that resources. There's I think a sense in reading the papers that there's a desire for people to practice in an ideal state, and then there's the reality of how we actually have to practice. And that disconnect can be challenging for those of us who feel strongly about social determinants and social emergency medicine. We introduced the idea of partnerships with those outside the ED, and that I'll leave because so many of the papers touch on that, and I think it's going to be a very important part of how we view ourselves and our relationships with our partners outside the emergency department. We talk a little bit about the ED as a social safety net across the entire socioeconomic spectrum. So while a lot of what we focus on are vulnerable populations, it's not to say that that is all we do. And the social forces that drive people to emergency department, while disproportionately affect the most vulnerable, the most marginalized, that it's not exclusive to that population. We talk a little bit about the ecologic perspective of social emergency medicine. So it's incredibly important as practitioners that we think about the patient, that we think about our healthcare system, and that then we think about the population of the community. And if we're only going to address one of those levels, then we will probably fail in making significant strides to improving care. We've touched briefly on the movement to institutionalize social emergency medicine today within our specialty, and I think all of us being here is a prime example of that. ACEP's commitment, SAEM's commitment now, and the fact that we are now seeing within centers throughout the country, in universities, people addressing the issues that we're talking about today head on is a movement in the right direction. And then finally, and perhaps very importantly, the research agenda that had been neglected for so long, but now we're making breakthroughs, and slowly the NIH and other agencies are moving towards recognizing that the work that we're doing for these populations is incredibly important. And again, the individual papers really sort of highlight that movement. So that's the overview of our paper. And I'll, in reading our paper again and then reading all the other papers, I have some questions. I can pose the questions, Harrison, or if you want, I can pause and we can just open it up for discussion, however you see fit.
We're going to let the commentators chime in for a few minutes also, but yeah, I would say go ahead and get your questions on the record, and then they'll inform our discussion and thoughts.
So I think the biggest question I have is, how do we message our views and what we're doing here today to the rest of our specialty? Because there are skeptics among our ranks, and we're asking for people for some people to think about emergency medicine a little bit differently, or at least take what they have known about emergency medicine, but now do something with that information. And so what is reasonable to expect of our colleagues? Are we going to expect everybody to be activists? In the absence of that as a possibility, what resources can we provide people so that we can make the practice of social emergency medicine and the consideration of social determinants easy for them, so that it's not a barrier? How can we normalize social determinants so that it's as mundane as hypertension and diabetes as risk factors, for example? And then, can we create new allies in this movement? Can we get payers and care delivery systems, the non-disadvantaged patients, to care about the principles of social emergency medicine the way that we do? And then, I'll sort of my bigger question is, can we align all of the interests of leadership within hospitals, the payers, to get to a place where we view centers of social emergency medicine and reimburse that in a way that we do similar to stroke or STEMI centers. We were joking last night that should we have EMS divert all vulnerable populations to SEM. And I wouldn't necessarily advocate for that, but can we take the principles and recognize that there are some basic things that all EDs should be able to offer, like 24/7 social work or access to patient navigators or timely psychiatric evaluation, excellence in treating substance use disorders? And can we take some of these principles and help emergency departments conceptualize how they want to approach care for these populations? That.
All right. Ewan, you want to have a crack at that?
It's so exciting, first of all, to be here. And I'm really humbled to be able to comment even on both Frank and Kahimi's work, and excited to hear your input. I don't have anything new anymore to say, but I have a couple of comments. And I think, first of all, again, this is an amazing place to be and time to be right now. And it's exciting to be inventing what we call social emergency medicine. That being said, I have a little bit of reservation. First, being here, I'm a terrible introvert. And I've always been on the outskirts of every organization. And to come here and try to form a group with a specific mission is a little bit terrifying, since it really means that we have a responsibility to actually grow our individual efforts and really become effective in promoting our mission. I wanted to comment, number one, about a lexicon and our mission. So number one, social emergency medicine is a very difficult concept for me to say in one soundbite, in one tweet, in one sentence. And my husband, I'm not sure, even knows what I'm doing. And in order to develop this specialty, I think we really need to develop a language and a lexicon to talk about what we do and really deliver the urgency of our mission. And secondly, in terms of mission, I think that we really need to be inclusive. Emergency medicine is social medicine. We are, I think, a lot of us from academic institutions. How do we unite our mission with safety net hospitals, with people in community EDs, with community organizations who are directly addressing social determinants of health? It's a huge mission with a huge requirement of collaboration with not just different sectors of medicine, but throughout society, and we need to be able to enunciate that mission and make it understandable and important to all that are involved. So while I believe it is an ethical responsibility to care for the people that come to our doors, if folks are not interested in that ethics, it's scientifically proven that social determinants of health affect outcomes. And so we need to turn our language and express social emergency medicine in terms of efficacy and science, or in terms of economics, as Dr. Lippert will speak about, and pragmatism. Any way to accomplish our mission, I think we need to be clear about the ends and not get tied up in the language. Education is paramount, and while there are a lot of medical schools speaking about social determinants, I still believe it's kind of on the fringes. Dr. Lippert and I taught a class to 10 people in the Stanford medical school, and those 10 did not need our class. They were the converters. And similarly, at this consensus conference, I would really urge folks, I think a lot of you are educators, to think about how we can subvert, wend our way into biochemistry, into anatomy, into physiology, and show our students and our trainees that social determinants are absolutely the same, have the same scientific basis and urgency as learning, how to listen to the heart and read EKGs. Next, specialization. I think that there's so much work that we have to do. We cannot expect every individual physician to be able to do everything. And as Dr. Shea said, we need some basics. We need to know how to screen, understand fundamentals, but we have to create specialists who will be able to address homelessness, address violence, addiction, housing, and we have done so. But to really integrate that into our practice and be able to call a consult, maybe divert everybody, and practice efficiently. And last of all, there is a little bit of trepidation, but social determinants of health are the political determinants of health. And I don't actually know the correct way to address those. But in this day and age, I think that it's important that we make a political stance in our hospitals, in our ED individuals, as an organization. As many of the institutions that have been supporting our population, not just our patients, are being dismantled. And I would really be interested in seeing how best this.
Good morning, I'm Suzanne Lippert. And it was really exciting to have the opportunity to just read all of the papers and then have the opportunity to comment on your paper, which I, very much agreed with the principles and was so excited to see it laid out so clearly. And when I was trying to think of, how can I contribute to what you've written, I really started thinking about the past year and a half, 2 years, and all these conversations I've had with family, and specifically family that passionately disagree with me. And I really was trying to think of, it has been essentially, a boot camp of trying to find common ground. And so I really took almost the exact angle that Jahan, you finished on in your questions of, how do we actually create a consensus, and how do we, engender broad support for these principles, and specifically with people that don't necessarily share the same values framework. Because I would like to see, this embraced by our specialty at large, and then expanding that outward, just as you were suggesting, well, how do we create new allies that don't necessarily come immediately to mind in administration and in other areas that we really absolutely depend on as far as getting things done. And so when I wrote my comments, I really tried to think about 3 specific areas that I think as emergency practitioners we can all agree on as consensus goals. And obviously that's just the beginning, brainstorm, and hopefully we'll just open the discussion for, how we bring these potential allies to the table. So in my comments, I, addressed ED crowding as something that, we all know and love, and obviously has incredible implications both financially and potentially legally for individual physicians and also the hospitals. And, that is intimately related to safe dispositions and how we're having patients, ED recidivism and ED length of stay. Then I also wanted to address, just these individual physicians that are expected to see 2.5 to 4 patients an hour, how to unburden them at the bedside so that this does become normalized. It becomes part of the routine, and that it is not something that people essentially reject simply because they feel overwhelmed by it. And I think that we really have an incredible precedent to begin unburdening those physicians. I mean, there's already things around screening and help desk programs that I think are extremely exciting. And we actually already have this within our specialty. We constantly work with multidisciplinary teams to provide trauma care, to provide stroke care, to provide STEMI care. And then, in Alameda County, we're working with the DA's office, and again, working out with the community and the other hospitals within the county to really address human trafficking in our county. So we have that expertise. It's about translating it. And then finally, cost, which is exceedingly difficult and challenging and exciting to try and actually bring in, because I do feel that that's one of the ways in which to bring people to the table and really just get leadership aligned as well. And I think it really, when I was thinking through it, is very clear that the impact of the social determinants of health on our patient population in particular also really impacts the day-to-day life of your emergency physician in the community, in the county system, in academics. I mean, it impacts our day-to-day life. So I do think that aligning our practitioners broadly through our specialty is possible when we start thinking about how we impact their day-to-day practice. I think that just goes really nicely back to Jahan's questions of how do we message our views to the rest of the specialty so that we do have a common language and a common ground that we're working towards, and how do we create these new allies?
All right, the paper's open for comment and question. Come on, you want to pitch in.
All right, I'll take the first stab. So regarding the questions that have all been posed, how do we message this to our peers? Because we all have different attitudes and philosophies and backgrounds. And my take on this question and how to communicate to our peers is that we focus on the interests that we have in common, not on the positions that it represents. And although all emergency physicians are not going to be in agreement with the mission of social emergency medicine, we all want to be effective. And addressing the social determinants of health allow us to be more effective in our practice, whether it's turnaround times or other productivity metrics. I mean, these are real things that we have to deal with in our practice because it affects our bottom line and our, some of the 20% of our income. So focus on those things that are that represent self-interest. But there's also, apart from the quantitative metrics, there are many qualitative issues that affect the burnout or the experience of the job. And we all have stories of how a certain day will make us want to not practice anymore. And I know some terrible stories that have to do with, prolonged psych boarding. And, one story that I'll share is not my case, but one of my partners in the state was trying to run a resuscitation that was unsuccessful. And outside the resuscitation curtain was a boarded mental health patient who was masturbating. And the family saw this, and he saw this. And so what do you do in a single covered ER when you've got those two things happening? I mean, at the end of the day, you just want to stop. But when doctors have those stories and you relate to the trauma that caused not just to the families and to that patient who's being boarded there for days, but to you, then you might be able to gain some traction in promoting the mission.
I agree with what you expressed. I think that to kind of change that picture or the mindset, I think it's going to really be to reach other people. For those of us, everybody in this room is here for a reason. We're all, social advocates. We have a very common viewpoint on things. I would suspect that everybody in this room has very positive feelings about these patients and so forth. I think to reach the other group of people, it's going to come all down to money, really, and to cost effectiveness type things. And I think what we need to show is that by addressing these needs up front, by developing other ways to address these important issues, that we save the system money. I mean, that's what legislators are going to listen to. That's what our hospital CEOs are going to listen to. If we can, unfortunately, it really comes down to that. And so we have to be very utilitarian about this, have to be very pragmatic and demonstrate that addressing these issues aggressively saves the hospital, saves the system, saves the whole U.S. economy money, basically.
We're probably in a little bit of a minefield here, I guess, but I think we have to be really careful when we say that, because I think there's not a lot of evidence so far that some of these interventions will save money, and I think it's an insanely difficult thing to prove, because when we address social determinants of health, we're not only trying to reduce, maybe ED visits or, improve access to primary care, but you're also impacting other use of services that we can't always measure hand in hand with healthcare services. So, for example, if you take a super simple example of housing somebody, if you house someone, maybe you reduce a few ED visits, maybe you don't. It's actually, I don't think it's super well proven even that yet, but reducing a few ED visits, even a bunch of ED visits, actually won't pay for the amount of money that it costs to put someone in permanent supportive housing, even though that's a very reasonable cost, and it's absolutely the right thing to do. And there are probably other quality of life outcomes and maybe long-term outcomes, like dying at home instead of an ICU, that would be very difficult to study and prove, that would come out of that. So I guess I want us to be really cautious about this idea that we have to be held to this standard that I feel like a lot of other aspects of medicine aren't necessarily held to, right? So let's just take the example of hepatitis C medication, right? Those are super expensive, very rare chemotherapeutics. Am I saying that right? Really expensive, and they might add a couple months onto someone's life, and they're paid for. And putting someone in housing might add a bunch of years onto their life, and we don't want to pay for that. So I don't, and the drugs aren't put through the same, scrutiny in terms of whether or not our healthcare system will pay for them. And I've never understood that. I continue to not understand it.
And I don't think that the things that we're arguing for should be held to an unrealistic standard. I don't think that we should throw money away, but I don't think that we're always going to be able to show that we're saving the health system money, and that should just be okay.
Go ahead, I'm sorry. I was just going to add on, I completely agree. And I've seen this happen with housing specifically, but has broader applicability. I mean, when we hold ourselves to the standard of this needs to pay for itself, we end up shooting ourselves in the foot. But further, I really agree with you and when she said that we need to make this normative, like as normative as anatomy and physiology, because this is as important to people's health as any of those other things. And I think that the cost arguments are really, can be good to get new people at the table in the short term. So I do think that there's value in the cost arguments. Certainly, I've seen that. So I think that's important. But
you can make the cost argument and not make it very well and make it sound really good and get a bunch of people to the table. I just kind of feel like you're sort of maybe not being really truthful, but at least it gets people interested.
Yeah, but I think we also need to take the kind of long view of this, right? This isn't going to happen overnight. Like, I don't expect that even in 5 years, all emergency physicians are going to think that these are important issues. But I think that as we normalize it, as we make this part of kind of the routine, as we're educating our residents, as we're educating the students, hopefully it will become the new normal, and it might be gradual, and I think that that's okay. But I really think that we need to focus not just on the cost, but also on the moral argument, but the fact that this is just part of our mission and part of what we do, and kind of come from that baseline.
That's going to be the challenge with the research question. When Rob first made his comment, I agreed, and I agree with you. But social determinants of health, the root causes are disenfranchisement, poverty, and access and lack of access and resources. And that requires money and power and resources. And if we're not advocating, when Ewan mentioned feeling politically maybe inept, I'm speaking for you, we have to do that. So even if it's not cost effectiveness improving that, we have to have access to power. And most of what we're talking about is our legislators and political power. We have to have their ear and drive that conversation to change this. And it does involve money I felt for the institutions as well as our systems.
This is a really exciting conversation for me, and so I spend most of my time, quite frankly, in public health. I'm also a practicing ER doctor, but I also oversee the health of all Detroiters, essentially. But I want us to also understand that what we're talking about right now is really the language of public health, and has been the language of public health for quite some time. So what I'm struggling with right now, listening to this conversation, is as emergency physicians, we're all interested and excited about this. We don't have to solve this problem and be going at this by ourselves, thinking that as emergency physicians, we're going to solve this. We have to go by ourselves to legislators, to hospital CEOs. I love my job because I speak both languages, and I have the ear of the mayor. And I have funders who are looking at me saying, hey, we want to support public health in Detroit. So I'm like, you know what? Okay, well, we're going to put this grant together. I'm talking to my hospital CEOs. I'm bringing in, of course, because that's my specialty, the emergency departments in the city. I did the same work in Baltimore. I think we have to think about our other partners, but really not, and I don't want to make this sound negative, but not expect too much of our as emergency physicians of what we should do and what we expect our other colleagues to do. But really bring in our other partners and think seriously about them. You go to any public health director, and wherever you are, they will love you, they will embrace you, and they will go with you to your hospital CEO and help you with this and write grants and all that, because that's just the language that we speak.
Suzanne, I think Jerry's been standing at the microphone, and then we'll come to you.
I just wanted to comment that I think we're going a little ahead of ourselves. This is, what we're really talking about is changing culture. And as you just pointed out, this culture change exists in other places. In the world of public health, social determinants is a whole specialty. And in the School of Medicine, it exists as 3 or 4 lines in a week during the second year of medical school, perhaps. So in the ways that as Lewis pointed out, Virchow talked about the relationship between medicine and politics, and what he meant by that was all of the social interactions in our society. This is a huge, huge topic that we're not going to fix in a moment. What we're talking about is how do you change culture, and changing culture has to do with a lot of things, and it takes a lot of power and money to have easy access to ways to open a discussion for the larger community. And we fight with that all the time in our society, because the people who have access to power and money are often fighting for things that most of us in this room oppose. So how do you deal with a society where all the power and money and influence is in the hands of those who don't want to make the changes that we want to see, and yet how do you go forward? That's a very complicated process. It's not going to happen overnight, but I would like to remind us that it's not impossible. We have all in our lifetime seen huge social shifts in the culture about smoking is an obvious example, about women as human beings, not as some second-class group, about civil rights. There have been things that we've changed the terms of the discussion, and I love your comment that we need to make this normative. We need to make it that we think about social determinants in the way that we think about other aspects of medicine. That can't happen easily. It's not going to happen overnight. It has happened in other places. We can make it happen, but I think to jump from the very first paper into how are we going to do this is jumping way ahead of ourselves. So for me, that's the longer term goal of this conference, is to address the many issues that are raised in the papers, and then to start to talk about how do we normalize this concept of social determinants of health in a way that starts to change the larger medical culture. When I started out in medicine, the culture of medical school was enormously different than it is today. And it needs to be yet again enormously different in the future, but that's possible. How we do that is going to be a little complicated. I don't think we're ready to talk about that until we go through some of the other larger ideas that we need to address, that I know we are going to address.
Suzanne?
I was going to kind of comment back on a different topic. I mean, I think that it's very true as well as far as the culture shift. But I also think that, again, we're not doing that alone. Like, there is this larger culture and expertise that already exists that, we just have to also embrace and work more effectively with. And, my original thought was going back to the cost question, because I agree. I don't think we should be pandering to, just that as the only metric. But I also think that, there's a shift in how we're trying to measure things as well. And, there's social impact investing as a, growing field, and really trying to come up with metrics that, are as valuable as cost, that shows the benefit. I think also speaks to the legislators that actually do have to be beholden to their constituents at some point. So when bringing up cost, I do think it's essential to begin talking about and figuring out how to integrate into our language so that we can get those allies at the table. But again, like you were both suggesting, totally agree that the social impacts also, if we can agree on, what those should look like, that is another incredibly powerful potential consensus goal.
I was just going to add, I hear a lot of tension between how are we going to move forward, and I think that is an important question. I'd also like to add, one of the things that I'm most interested in hearing from the group is what works. What do we know works? And I'm also skeptical of, it can't just be about reducing ED visits or reducing hospitalizations. What do patients care about? What's their priority, and how do we address that priority? If it's housing, how are we actually going to functionally do that? How do we involve the ED? What do the care teams look like? How does it happen for an individual clinician? how does it happen on a population level? That's one of the things I'm most excited to hear from the group about your experiences and your studies and what you have seen work in your own EDs and what other people have seen work, and hoping to bring that back to, my home team.
I just want to interject that I think one of the reasons that the cost argument is so difficult, and maybe one to put off at least for a little while, is that one of the historic problems with this argument, and I think that Maria's point is part of this, is that the sector of the economy that makes the investment may not be the same sector of the economy that reaps the savings. And so the cost argument has never really gotten a lot of purchase. The cost per quality argument, which is the cost effectiveness of any given intervention from the patient perspective, has gotten purchase. And we haven't actually taken very good advantage of that as emergency investigators, I don't think. It's a flawed metric. The cost per disability adjusted life year saved or cost per quality adjusted life year saved, it's definitely a flawed metric, but it is a language that's spoken by people who make these decisions. And so cost savings to the system might be difficult to demonstrate, but a benefit to somebody's life experience that doesn't break the bank is something that I think that we can work toward. I think it was Jahan, then Appa, then Rob, and Dennis was in there. So Jahan, Appa, Dennis, Rob.
I completely agree with you, Harrison. I think that the cost calculation is very challenging when you're, payers, and the payer may be different. It just really depends on what perspective we're talking about. And I think we were probably moving in the right direction in this country with respect to really thinking about value-based payments and episodes of care. And I mean, who knows where we're actually headed right now. And I think, Kemal, to your point, like we do, and we talked a little bit about this in our paper, that we should really be thinking about the care continuum for our patients. And that's really where you might actually start seeing some of the cost arguments bear out. Right now we think about these patients in single episodes of care, and there's a cost for a single episode, but the work that you're doing is really trying to say, let's link everyone through all the social systems, and now you have a continuum, an entire care cycle for these patients, much in the same way that you would for hip replacements, right? They touch on so many different institutions going through that episode of care, and we should start thinking about these patients in that perspective, and then we can see, is there a cost argument to be made at that point? But right now, when we're just so, these fragmented episodes, it's really hard to know if what we're really doing.
I'm just curious about, sorry, the Deathly Child virus. Like Harrison, and from the group, what you guys think about the role of ACEP and that this group being part of ACEP? Because when I look at ACEP's mission statement, it hasn't been revised since 2003, and it makes no mention of social emergency medicine or about kind of what we're here for. And I just find that very interesting, because I think part of the change that as emergency physicians we're going to probably bring, well, I'm assuming our voice will be through ACEP, but I want to know if that assumption is kind of what this group shares. And if it is, then I think it seems like nobody's ever reading this mission statement if they haven't updated it in 14 years. But it seems to me worthwhile in terms of just branding of emergency medicine and rebranding our specialty, having this be an essential part. You always say, emergency medicine is social emergency medicine and social EM is emergency medicine. But that to me seems like something very concrete that's missing from the definition of our specialty. But that could potentially be very powerful to see that ER physicians as a nation kind of rebrand ourselves as being social advocates, and that's just what we do. And I think change can come when that new language, like Ewan says, this new lexicon, if that's what you go into is the field of social emergency medicine, that's what we do. I think that could be so powerful for the next generation of physicians who come through, if they just see that that's what we all value this as. And that's a very different direction than what you guys are talking about with the nitty gritty, but I just wanted to bring that up as kind of maybe a concrete project. If you think that has value, then that's something I'm so interested in being a part of, and other things.
Sure. On the board of directors of ASAP. The mission statement is a one-sentence statement that you can spit out repeatedly and memorize for your life. We do have priorities that the board puts forward on an every year or every other year where we do our retreats and come up with that. And the whole creation of this social medicine, and it's on there starting 2 years ago. You can start to see things like the diversity and inclusion task force being a priority. You can now see social medicine gaining, oh, let me tell you, ASAP hears this and ASAP recognizes this. And so, thank you. You may not see the mission change, but we do have an entire list of priorities and tasks that we put forward every 2 years, and this is not just on the radar. This now has a place there.
Just a clarifying question.
It's in our strategic plan.
Is the mission statement what's written on the wall as you come in to this building?
I just looked at it.
Is that what the mission statement is?
That's the mission statement.
So, I mean, to me, the mission statement fits perfectly with social emergency medicine. The mission statement that's on the wall here is the American College of Emergency Physicians promotes the highest quality of emergency care and is the leading advocate for emergency physicians, their patients, and the public. To me, that is also this.
Right. Okay, I'm going to go back to our order. I'm sorry, Jay. But we have Dennis, Rob, and then Jay, and I'm going to take Stephen off. Unless, Stephen, do you have another?
I wouldn't mind.
Okay.
So I think I just wanted to get back to Ewan's point of normalizing, and what Kelly also commented on is, I think the AAMC is looking at changing medical school education yet again towards competency-based education. And I think there is a huge opportunity here as we think through competency-based education to make social medicine a key component of that, and starting to bring this into sort of the learners. Obviously, that doesn't address existing practitioners, but thinking about the pipeline issue. So just wanted to throw that out there.
I'm going to take the chair's prerogative and go, because this point, it has already come up half a dozen times, and in the papers it comes up a dozen times, and I just want to say EM can own that. So who's going to teach the social determinants of health in medical school? We are. So we just have to figure out how to, intercalate ourselves into the curriculum. Some of us already have, but this should be our space. I think, medical students are going to devalue it if it doesn't come from a doctor, right? So it has to be a doctor. What department teaches cardiology? Cardiology does. What department should teach social determinants of health? The emergency department. It's our lived experience every day. So I'm going to back away from that. It's Rob and then Jay.
Yeah. In terms of the cost argument, I wasn't necessarily referring to traditional hard outcome measures like qualities and so forth. I like what Jahan mentioned, that you can really look at sort of non-traditional, other sort of quote cost or cost effectiveness outcome measures, and also take snippets of things. We don't have to show that the whole piece of addressing your social determinants of medicine are cost effective, but we can show small programs are cost effective, and we can even, like, as I put in my paper, an example of, you can kind of appeal to the basic face validity or instincts of emergency medicine docs, and put forth questions like, would you rather have a 24/7 social worker in the ED, or 4 hours of chest pain protocol available to you? Probably less cost for a 24/7 social worker. And when you put it in those terms that ER docs and others can grasp, maybe not in such hard outcome measure type terms. When you put it in real existence terms, I think the vast majority of docs would say, well, yeah, of course I want a 24/7 social worker instead of a chest pain 4 hours of chest pain, rule out a day kind of thing.
Okay. Let me build a little bit on what Rod just talked about, because I very much appreciate, Gary, what you said before about culture. To me, what culture really is about, it's about an alignment of beliefs and actions and more. That's part of it. And before alignment has to come, before we can align beliefs and behaviors, we have to engage people so that they're interested in doing that. And so for me, one of the things that I would like for us to think about is, how do we engage not just our administration and not just the deans, but how do we engage our colleagues? How do we engage our fellow emergency physicians when, if it's like my last shift working in intake, I saw 40 patients in 12 hours, including about 6 or 7 that I admitted who never should have come to me in the first place? And how do I engage my colleagues who are under tremendous pressure for quality metrics and productivity and patient experience to not only look at the task of taking care of the patient with the disease that's presenting right in front of them, but the social determinants that led to their getting there in the first place, and it will affect whether they get their medications and whether they can make follow-up appointments and things like that. I think we have to be clear that there are some administrators who are just not interested in this, and that we're going to have to drive the process ourselves. We're going to have to be leaders in this, in the same way that you said, who owns teaching this in medical schools? Well, we in emergency medicine do. And I think we are going to have to drive this process ourselves, both with our administrators and with engaging our colleagues. So I'm interested in hearing from our very erudite panel and everyone who's here, their thoughts with regard to how do we engage our colleagues who are very busy just trying to stay afloat.
I'm just so overwhelmed by the intelligentation around this room. A couple of things. I'm tremendously pragmatic, and I don't apologize for it. So I want to speak to a couple of things. First of all, messaging and getting people's attention. I hate to say it, but America still works off the one-sentence soundbite. We have to figure out and come up with the ideas. Who are we messaging specifically with which soundbites? For instance, the one I open the conversation always with is, I can tell you more about your life expectancy by your zip code than your genetic code. And simple things like that that engage people to get involved with this helps. 2, we do need a certain amount of metrics. That's something this group can come up with. What are we actually going to measure? Because we have to prove that something that we're doing here makes a difference. So CEDAR is the example that the college has now embarked upon to measure things like sepsis outcomes, etc. We should come up with a metric that's going to define success. You and I had this conversation at length going into this. We can't overextend ourselves. There are so many social issues. There always will be. The council's going to hear in a month about a resolution about global warming. Thank you. Clean air, clean water makes a huge difference, but I don't think ACEP's in a position to influence global warming. That's my own personal opinion. Maybe that's something we want to address, but we can't overextend ourselves. We've got to pick some areas we can show success in, and that's something this group can give us direction on. And finally, since I'm so pragmatic, I want to come out of this with tools, actual tools that I can use. We eat an elephant one bite at a time. I want little successes, and economics has to be one of those equations. If you got the little study that showed the little thing that saved a little money, that's a start. And I want to hear some of those things, like you'll hear about the emergency department information exchange from me at some point in time. You're going to hear about other successes from all these things, and that's beautiful. Let's give the college, who are going to be our apostles and are going to teach this, those little tools that they can go home with this message and make some small inroads on. Thank you.
That was a great discussion. Thank you. And I'm struck sort of by the conversation today, this morning, a little bit about how this is almost I would say, an us versus the rest of our community. And I recognize that there's a lot of thought leaders in the room, and that we imagine ourselves to be the positive deviants who will be able to learn and take back to our communities tools that will be able to spread. And I think that's exactly what needs to happen. But I also think that we need to recognize that getting back towards what I think both Jerry and Hemel were talking about, is that we need to be able to start with identifying what works and sort of get the bug ourselves. And maybe that's what this conference will do, and I hope it does, because we probably all have some internal conflict and around this issue. We may, at a high level, think social emergency medicine and addressing the social determinants of health is what we do and how we and drives us every day. But we all know that we very well can get bogged down in a bad shift, and we probably are always wrestling with our own conflicts around how to basically accomplish everything we need to do on any given day. And to build the bandwidth and capacity to actually activate this and to spread it is going to take a lot of work. So I'm really excited to think about learning about what works and having my own internal transformation so that I can take it to my community and to continue to spread it through the rest of my field.
I find this conference to be so terribly exciting. I can't tell you how excited I was to see this unfold. And again, great credit to Harrison, to the vision of ASEP, and many others in the room here that brought this discussion to the forefront. And I was struck too by writing the papers that we're sort of all, perhaps maybe where you were going, Zach, was we're all kind of living in our own little worlds going, we got to do something about this. Something's got to change here. Something's got to give. And I think this is really the start. And so let me just step back a little bit. And first of all, I do want to comment on Harrison when he says EM has to own this. And I thought, gee, that just sounds like the acute airway arguments we had with anesthesia. We own the airway. We own this, and get out of here. And we're going to take care of this. And I also disagree with you, Harrison, about who is best able to teach EKGs to medical students. It's actually emergency physicians. We do a better job than some cardiologist digs deep into all the sorts of things that medical students start to ignore. But I want to get back to the paper and where we're starting with, and I think that the overview that this paper provided was really excellent. Virchow was the lead. Virchow was saying, hey, what are we going to do about tuberculosis? We got to change the housing. It's a political disease at the time. We didn't know that tuberculosis was caused by a little germ until later on with Koch and Koch's hypothesis. So I think we need to get back to where the cultural shift is going back where we've been. And I think it really gets back to our colleague in Detroit. The early 1900s, up until the early 1900s, medicine and public health were joined at the hip. And there was a divorce. And Hopkins started the divorce, the public health school. And medicine went on the realm of biomedical approaches, and we all learned biomedicine, and we lost a lot of that along the way. And I think this conference, this thinking, is bringing us back to what I'm again advancing in my own mind and seeing this happen. We're not doing this alone. Is a biopsychosocial disease model that gets us all kind of bound together. So we had this divorce in the 1900s. We're seeing that divorce being reconciled with leaders leading public health as well as emergency departments. We have a medical school in Wisconsin, the University of Wisconsin School of Medicine and Public Health. So that I think we're coming back together, and there's a conference beyond Flexner. It's held annually. I think that's where we're going to see our colleagues struggling with these same issues. So I don't think we're going alone. I think we can lead the discussions as appropriate as we can because we see it. But I don't think we can do this alone. We can't. We know we can't. But I think that's really what I think we're seeing with this initiative and this paper. And so we don't practice alone, and we don't do these things alone. So we asked for a tool. It's interesting, I'm in the midst of advancing a tool in the emergency department. Simple, the Cardiff model. Cardiff, Wales. When your patient comes to the emergency department, laceration of the face, we have all these things we ask about, and then the plastic surgeon started to ask, where did you get injured? Bud's Red Top Inn. And that change, where did you get injured? When I was practicing in community medicine in the evenings, I wanted to know where they got injured, so I didn't want to go to that bar afterwards. Where did you get injured? The assault patterns of Cardiff were then put up on a map. Where are these injuries occurring? When are they occurring? And it's social epidemiology, forensic epidemiology. Where are these things happening? And they looked at that, developed policies and programs with a multi-sector, police, public health, everyone's there, going, you know what, we can do something about this in this neighborhood. So it's a little thing that emergency departments can do, is ask the question, where did you get injured? We asked the question, where did you just come from, right, with Western Africa. So that's interesting, is the cultural shift of asking the nurses to do that. It's been an absolute fascinating example of the challenges of what we're facing in shifting emergency departments by asking a simple question that takes 30 seconds. And the cultural shift in the children's emergency department was immediate. Of course we're going to do this. In a public hospital like Grady, immediate adoption. In a private community center, in a community emergency department, really, what is this going to do? And in our adult emergency department is, no way, these are adults. They did it themselves, we can't do it. It's not necessary. Yet it's shown reduction in violence, 40%. That's a little thing everybody can take home to their emergency departments and look at that. So I think we can't do this alone. We're not doing this alone. We have a cultural history. I think, to your point, we lead the way in this, no question about it. Owning it, leading it, we can do it as we've done in so many areas. So this paper really starts us thinking in that right direction, and got a lot of work to do. I don't think we're getting ahead of ourselves, but I think we got a long road to go to really have this culturally adapted across emergency departments across the globe. And this is a great start in that direction.
Just want to interject, and then Nate, and then Lou, I think. The structure of the room is not what we had envisioned when we planned the conference. I really don't want this like to be a balkanized thing. I'd rather have it be sort of the backbench of Parliament, maybe. I want people who are sitting there. This is all a room in active discussion. So I hope there's not any kind of artificial lines between the people who are sitting at the U and the people who are sitting at the class. We hoped to be able to rearrange those, but it turns out they're fixed to the floor. So, that option was taken away from us. And so we'll have Nate and then Lou.
I think we just, on one side, I think it's important to recognize that, like, this is what we do on a day-to-day basis, but a lot of people don't understand it, right? And so I think we need to bring voice to that and carry it with a badge of honor. And, I think that will entice a lot of, like, our residents that are going into international and trying to do all these other things where they can do the same stuff here at home and sort of create a much bigger appeal. I think the other thing is, there's been a lot of discussion about this is going to take a long time to have a cultural shift. And, I have an urgency of now. Every day I'm on a shift, people are dying, or, they're living terribly, and they have an urgency of now. And our systems are built to be slow to change and to slow to shift, and it takes oftentimes pretty traumatic events to make things happen. I live in Baltimore. At Hopkins, we had an uprising about 2 years ago after the death of Freddie Gray, and things across our university changed dramatically as a result of that. There's tons of investments that are going into the communities that weren't happening before. And so I agree that change is often slow, but sometimes you have to sort of approach it with a ferocity and really harness that fire that's burning inside you to really try to make things change. Because Otherwise, it will go really slow.
So I think a few of the comments, just briefly. One, I don't like organizations either. So I don't think the organization means much. I would say you have to act up. You have to do what's right. And you're going to be in a lot of different organizations. And I think that when I started in emergency medicine, I don't think that there were no constraints on how we did things. There was little knowledge and there was little organization. But no one was going to tell me how long I was going to spend with the patient to find out speaking in French for half an hour to get the story. So it's not acceptable that we don't have translator phones at every bedside in every hospital so that you can get the history. If you don't get the history, you'll rely on the laboratory results you get, electrocardiograph and things like that. And so yesterday I heard from Brianna that everybody doesn't use a translator phone in Los Angeles to speak to the Spanish patient. So they're not, the communication in plenty of hospitals that I know of, in New York, they're not doing this. So that people get less than that. You can't, I'm surprised Jerry didn't quote Peabody, something like, if you don't know the patient you're talking with, you can't understand the disease the person has. Everyone said that. If you don't speak the language, you don't spend the time, we're not going to get there. It can't be a fast medicine process all the time. If the person has ventricular tachycardia, it can be fast for a while, but then it has to be slow, and then it has to start fast again. So we can't be trapped by the rules that someone set to make money out of the system. If we don't do a job for the patient, we've failed. I mean, we do, all of us could say, you can rush through with someone who has an ST elevation MI and get the person to get stents upstairs and forget that he or she doesn't have the money or a place to go, and so the person's back and dies a few weeks later in the process. We've lost a capacity to function if we get caught up in rules that are set to make money and not to make care. And so these are things that really have to be worked on much more extensively, because we're not going to satisfy everyone we work with. We have to satisfy ourselves and be independent and satisfy the communities in which we work. And I don't think that, sure, the people in this room, everyone goes to another organization and find lots of people who have similar beliefs. It's very common that we find people who agree entirely. As I said, the people in the population health, which acts as a cloud-based support system for everyone in the medical school, we all have similarities. The urologists and the surgeons, the people who are working on where the injuries occur and why the bicycle lane isn't good there. We're studying that with emergency physicians and trauma surgeons and others. If we don't do that, we're not getting anywhere. And we have to change the beliefs that people have about what medicine is. We've abandoned it when we take shortcuts, and we have to do this correctly. Otherwise, we're just kicking the ball down the road. Someone wrote this piece about doing cardiac arrest. Sure, we thought we'd win the battle by putting in chest tubes and defibrillating people, and they'd walk out of the hospital and be fine. But we obviously failed with that 40 years ago. So we have to have collaborators, and they are there, and we have to go get them. And we have things to say that everyone's going to listen to. And this is a political battle. It's not going to be won in organizations. It's going to be run probably in the street to get things done. There is no choice. We get much more serious about finding the right solutions for the problems we're all going to be passionate about. And that might not be ones that everyone else in a big organization are satisfied with. But this isn't about all the things we've written. It's the things we didn't write that are really defining our political climate that have to be addressed. And so you can start and make friends locally with things that are acceptable to them, but you then have to go to really where the action is at a much broader base.
Jennifer, and then Leah, and then Chris.
Continuing on the theme of this being a cultural change, my sociology grad school professor used to say that structure causes culture, that a culture change comes from structural changes. And so I think that's what is so exciting about this conference, is that this is giving a structure to what we do. You know, someone said, my husband doesn't even know what social emergency medicine is. My husband asked me the same thing. What is this? And I said, it's everything that I do, and now it has a name. If I could give, though, a hopeful sort of example, I think that the culture change, I think people might be perhaps our colleagues might be a little more ready than we think that they are. I'm coming from the background of an academic program in a classic inner city teaching hospital in a city with very few resources, right? Does that sound familiar to anybody else? We always, we're from New Orleans, right? We always did things in the community. We always had a very important part of the community, and we just went about our business. And then a couple of years ago, and probably it was Katrina that spurred this, we realized that people were seeking us out because we had some connection to the community. So we flipped the script and we really made it our brand. And we branded ourselves. If you go to our website, if you see our videos for residency recruitment, it is all about the social determinants of health and community medicine. And so we sort of expected this huge backlash, like, oh God, we're not going to get any applicants except the diehards. And what we got is an incredible response. We have people seeking us out because of this. But what we also found is that the kids who wanted to come to us anyway, because we have a great trauma program and we've got all the regular stuff that people care about in emergency medicine, they weren't necessarily coming for the social determinants of health, but they were exposed to it and it was normalized for them. So, like I tell them, you don't have to drink this Kool-Aid, but you're going to be at the party where the punch is served, and you're going to see what happens when other people drink the Kool-Aid, right? And you don't have to believe this necessarily with your heart, but going back to the cost argument, this argument makes sense to your head. You might not passionately believe in this like many in the room, but there are so many logical, pragmatic, practical reasons why including this in training and including this in your daily practice makes sense, if only just because it might keep people out of the emergency department, keep people out of the inpatient. And really within a very short period of time, we got pretty great buy-in. Now that's just a small example, that's not a specialty, but it was almost as if people they saw this was a problem, they were tired of being frustrated, and they were far more willing to listen when we said, yeah, we're going to own this, we're going to admit it, and we're going to try to start doing something about it. So I'm hopeful that our colleagues will maybe not be so difficult to convince.
Hi. I just wanted to talk about, to Dr. Kaplan's point about very, community physicians who are moving very rapidly might not feel that they have the time or the ability to make a difference. And when you actually ask a number of physicians around the country of why they're not asking and why they're not doing anything about it, most people feel pretty disempowered because they don't actually have anything to offer their patients. So I think one of the things that maybe a culture shift both in medical school and as this group in its entirety can come up with is specific tools that we can provide physicians, right? So like somebody else mentioned, we are not doing this alone. There are many, many organizations and other institutions that are already working towards how do we address these problems and being able to coalesce them and make them accessible so that when you are seeing 4 or 6 patients an hour, you have your 1 or 2 questions that you're going to ask and then ability to refer somebody that maybe there's other subspecialists that then exist so that they can take over in the same way that you would refer somebody to a urologist or a cardiologist for something quickly. You could refer somebody to an actual social navigator in a relatively quick checkbox. So I think somebody in one of the commentaries made the point of how important it is to offload this from the practicing physician. And I think really to expand it on a global level within this country, that's something that we're going to have to embrace. And I think it's incumbent on this group in particular to come up with exactly which tools and which subsets we want to aim for first to be able to provide that to people. And I think educating medical students and bringing that up and having so many more young thought partners on how we best do that in that system is really where we're going to make a humongous difference, even though there's an urgency now as well.
So before Chris, it's been brought to my attention that I'm probably the only person in the room who knows everybody here. So if you will introduce yourself at the mic the way we do it at SAM and other meetings, I think that will help other people get oriented to the entirety. So Chris Barsati.
I'm Chris Barsati. I work in Vermont and Massachusetts. I'm a community practice nurse physician. And I'm also chair of the Trauma and Injury Prevention section of ASAP. So come to the section meeting this year. So it sounds like what we're talking about here very much is trying to tip a social epidemic in medicine, how we think about this topic. And sometimes a few large events can cause an epidemic like this to tip, and certainly money helps. In the interest of looking to create allies, I went to the Gates Foundation's website, and their value statement at the beginning says, all lives have equal value. We are impatient optimists working to reduce inequity. Kind of sounds like what we're talking about. And so I want to issue a challenge to Stephen because he's a pragmatist, and if you drill down at the Gates Foundation, and Gates is really important because of the size of their endowment. According to an article that came out last month in Philanthropy, their current endowment is $40.3 billion. They're going to get $36.1 billion from Buffett, and their net worth is about $90 billion on top of that, and they get half that charity. So they're talking $120 billion of money in the private sector that they want to give away. And also, apparently the foundation has the goal of dispersing all those funds within 20 years of the death of Bill and Melinda. So 50 years, giving away $120 billion. It's hard work to invest that money very well. And if you go on their website, you find that what they don't fund are projects addressing health problems in developed countries. So my challenge is for Steve and anybody else to create a pitch that will convince the Gates Foundation to change this in their bylaws.
My name's been on speed dial at the Gates organization for 10 years because I'm from Seattle. They're very internationally focused at the moment. It's hard to get them to look at the community that's 4 miles down the road from them. We're trying. If somebody gets me an hour, I'll drop everything and be there tomorrow.
But no, my point is that there's a lot of money in the private sector, and it needs to be, in order for our physicians to get access to those mountains of money, you have to present yourself in such a way. You have to create a strategic research agenda, and then you have to pitch it properly to these public, which is a different way of pitching yourselves.
Really quick, it's global health. And global health is different from international health. Global is local, global. Pitching this, framing it is so important and perhaps very, very timely. There are disparities in Baltimore and Milwaukee as there are disparities in other parts of the globe. And framing it has got everything in the world. I think this is a great challenge.
Sandy, Brina, and then we're back on track.
Sandy Schneider from ASEP. I promised myself I'd be quiet. It's not even. I know, I lasted an hour and I already broke it. So what you're really talking about here is making change, and most of us who've been through courses on how to change things, there are several structures that one can use. There are two that I think fit this. One is you start with change with a group of true believers. That's your core. That's this room right now, because everyone in this room, I'm going to assume everyone in this room is a true believer. And then you have the next circle, which is the most important circle, and those are the people who can be swayed. And you're talking about the pitching the right message to those people that resonates with them, not necessarily with you, is the way to bring them into the true believers. So what will bring those people into your group? And then the outer ring is the non-believers and the never believers, and you just ignore them. And you hope that your circle with your true believers and now the newly believers will be large enough to quell those people. So that's one structure, and I think you're talking around that, and I think keeping that framework in mind might be helpful. The other comes from the course that I took in Harvard, and I'm blanking, Ian Trevelyan has this theory that in order to make change, you have to have the right people, the right environment, and the right reason. And it was said in us that if you don't have one of those three, then you change that. And so if you have the right people in the right environment, but you don't have the right reason, then you create a crisis to make that reason resonate. That said, I think the right reason is there in this case. I think the environment is a bit touchy right now and may not be the best environment, but we perhaps can work with that. And the right people are in this room, but require some structure and some messaging and some people who may be less engaged to be able to step back and say, that doesn't make sense to me. That it was kind of going back to a lot of people with that. Jay was talking about what resonates with the practicing physician. what resonates with the Gates Foundation, that may not be your reason for being here, but that may be the very reason. And that's why you need a structure, an organization, a something to help make this happen. I'll shut up.
I am Brina Tyra from UCLA, from all of you UCLA. So I just wanted to add a little bit to what Dr. Goldfrank had mentioned about the language. So I think when we're talking about social determinants of health and the emergency department, right, a lot of what's been said so far is talking about social navigators and how do we link people to other resources. But there are really three key social determinants that we need to recognize impact every patient encounter, which are language, language justice, the availability of language assistance to all patients, cultural competence, and also health literacy. And so really, I feel like that triad needs to have a key place within social emergency medicine, because those are never social determinants that we're going to farm out to someone else to navigate. And so I'd like to see that kind of in the messaging of the group as well. And then just to address the point about the Gates Foundation and this kind of global versus domestic, conversation, is that, what we've found and what we're trying to do at UCLA is actually frame it as a question of health equity, whether or not it's international or domestic, because, we felt in particular when forming our section in LA that in Los Angeles in particular, it doesn't make sense to talk about, global versus domestic when, our patients are on either side of the border, at any given moment. And so talking about global health equity is one way to kind of change that messaging and have people recognize more the connection between the two.
John?
I think we talked a little bit about aligning the cost argument in order to make a case for some of the principles that we're talking about. And I think we've touched a little bit on another sort of outcome, which is just the practice of our practice of medicine. I think some of the best ideas and the stickiest ideas, the things that work, are the things that just make what we do better and easier and give us better job satisfaction. And that might be another area where we can make inroads with our colleagues. I mean, Dennis is shaking his head because he knows, he built a help desk, which, I don't know, is your help desk cost effective? Probably not, but, there's no way anyone's going to let that thing go, right? Because it changes how you practice medicine. Or at UCSF, one of our colleagues, Jim Hardy, created a partnership with a Salvation Army shelter where they have comprehensive mental health and detoxification and transition to housing. And, no provider is going to let that resource go, regardless of the cost. And in fact, it turns out that it is in fact cost effective too. But we should also be thinking, when we're talking about messaging, when we're thinking about what we're going to measure in terms of outcomes, we should be thinking about programs and research agendas that quickly change, that are such great ideas, they rapidly change the way we practice medicine. And I think we'll make a lot of progress and bring a lot more people on board. We can highlight those.
All right. Catherine, before you speak, I neglected at the top of the meeting to identify the presence of the Linton Scholars here at the meeting. And Catherine's going to be, I think, the first of them to speak. But these are students and residents who are attending this meeting by a gift of the Linton family to the Levitt Center to sponsor their travel and expenses here. And we got about 50 or 60 applications for 2 medical students and 4 residents. And the quality of the applications was unbelievable. And the Linton Scholars who are here selected from that pool, I think will be the people who move this project forward. So sorry to interrupt him.
Hi, everyone. I'm Catherine Wolf. I am a MD student at Duke and also an epidemiology PhD student at UNC. And I just wanted to comment on something that is very similar to what a lot of folks have said thus far today. But I think as we're thinking about how we're going to be messaging this, both to trainees and students and also to colleagues, I think it will be helpful to think about the role of empathy and how we can sort of help foster that in people. We are all scientifically leaning, and we tend to think of sort of cold hard arguments that we can put on a piece of paper that will motivate people. But I think we've also all seen in our personal lives, maybe with family who we've been having discussions with, that when people really see how someone who is less fortunate lives and the things that they struggle with every day, that can be incredibly powerful, much more so than anything that they'll ever read on a piece of paper. So for instance, I have a couple people who I went to medical school with who, in our 1 week public health class that was mentioned earlier, were very much the skeptics. And then went to the home of, they had the utilizer of the ED and saw how much trouble they had managing their medications and remembering which pill was supposed to be taken 3 times a day and which of the blue ones was only taken once a day, and did a total turnaround. And so I think that we also need to appreciate that a lot of us are in privileged positions, which is why we are where we are. And it's so easy to forget, even for those who are naturally empathetic and sort of inclined to care about such things, how difficult life can be when you don't have those advantages. And seeing it firsthand really can do a lot to foster empathy and sort of open some hearts and minds to some of the arguments that we would want to make to them.
Derek Ashong, fourth year at Johns Hopkins. I think just 2 brief points. Number one, I think in terms of things that we can do to help offload ourselves as we're working clinically, thinking about clinical scores. We can all think of everything coming out of Canada effectively regarding imaging, right? And how that's rapidly changed how we manage. I think one thing we can think about is looking at research that can focus on that and provide us with specific questions that we can ask that are brief, to the point, and guide us in terms of who are people that are going to be high risk enough that we should just automatically get them in contact with some form of offloading person. May that be a social worker, case manager, or the like. Number 2, regarding our lexicon, I think we should be a little bit careful. I'm on the interview trail. And so when I'm talking to people about social emergency medicine, they're like, oh, you mean Twitter? Right? Right? And so I think that's something we should really think about. I think it's a great name. I think it's something we should continue, but people in our kind of active age of Twitter and Instagram and everything else, being careful about that. We can use information that's already been a part of public health, right? So health equity, I think, is an incredible, powerful way of communicating, as well as quality. I think these are things that once we incorporate, we'll do a great job in terms of continuing the conversation.
Eric, in my own defense, when we pitched the Levitt Center to the Levitt family in 2007, there were 5 Google searches a month for the term social media. It just wasn't a thing. We couldn't. If we had, we would have picked a different name. But
So just to say, once we're continuing the conversation, just to say, hey, it's a different thing.
I appreciate that.
Hi, I'm Rebecca Carbon from Brown, a 4th year resident. So I just wanted to challenge us to think about what we can accomplish beyond what we can do on shifts or even in the ED itself. So we're ED docs, but we're also community members, and we can step out of the ED to work with other organizations and with other departments in our academic institutions on more place-based interventions that will happen outside the ED. So like the ED is, I feel like, it's this untapped wealth of knowledge about our community, and there's so much information that we can gather in the ED about what's happening in neighborhoods. And we can use that information that we get in the ED to go out into those neighborhoods and work on neighborhood-based interventions as well. And in that way, we don't have to think so much about like, what can we accomplish when we're trying to see 4 patients an hour, but more, what information can we gather and sort of that we're just not taking advantage of to understand our communities better.
Hi, everyone. My name is Teresa Chang. I'm one of the Linton Scholars from UCLA, all of you. And so I wanted to bring up I think a lot about language. I think a lot about lexicon, because my own personal history is that I was inspired to pursue a degree in law as well because of the miscommunication and the gaps in language and the barriers that thus exist between policymakers and those on the ground who see the everyday realities of our actions and sort of the policies that guide them. And so one potential resource that I wanted to bring up is something that I think that we could maybe draw upon to strengthen our own arguments, is that there are so many resources out there that already exist, particularly in the legal land. I subspecialized in law school in international humanitarian law. And so looking at how human rights and the international guidelines that already exist, the language that has already been developed around what human rights naturally exist, because I think what we're talking about now is already very much rooted in this human rights law that have already been developed and thought about, and how we can apply these legal arguments and legal structure, and how that may also promote our own agenda when we reach out to policymakers. So it's just something I wanted to bring up because it's something I've studied extensively, and I think we're already talking about it. It's just also figuring out that messaging and that branding that can help promote our own agenda. Thanks.
Eric, and then I think we have Zach, and then we'll have a break.
I'm Eric Anderson from Northern Navajo Medical Center. I did a fellowship with Ewan at Stanford a year ago, and then I went to Rock, and one of the first things I wanted to do was to do the same thing or which was, and we did that like right away. So I'm coming from Northern Navajo Medical Center, and I was saying that I had done a social emergency medicine fellowship with Ewan at Stanford last year, and one of the first things I wanted to do was to do something like that on the res. And I realized a short time after being there that the thing that we needed the most was like just being good ER doctors. And so I think if we're thinking about normalizing this and we're thinking about how the zip code that you're in determines a lot of your health outcomes, one of the things we can do is think about, well, emergency care is somewhat poorly distributed, and I think that it's really easy for a doctor to go somewhere where emergency care isn't that good. And that's one thing that's so practical that we can do, is think about that as well. So and Jahan sort of talked about regionalizing social emergency medicine a little bit, which I agree with that concept. But I also think that one thing we can do is also encourage the disbursement of highly trained
Zach?
Zach Mizell from University of Pennsylvania again. So, one of the seeds that I'm hoping to plant or think about throughout these 2 days is what I think will be a natural tension between useful information that's generalizable and things that are inherently local, which in social emergency medicine, the more you think about it, probably is particularly relevant. I'm struck by some of the comments around cost effectiveness research or cost effectiveness analyses. And Harrison, I'm going to pick on a comment you said where I'm interested to hear a little bit more about how terms like qualities or ideas like qualities can be effective ways to translate, because I suspect that actually that's not necessarily the case. We actually just did a needs assessment of health policymakers and health system leaders around cost effectiveness information focused on Hep C screening and substance use treatment. And I just want to, a quote that came up, it was a qualitative study, but we heard this over and over again, was like, you have things like quality adjusted life years, and frankly, shit like that. There's nobody who's interested in that. Nobody. And we heard that like over and over again. And part of maybe a terminology framing thing, but also what we heard was that ideas like that are often that speak to sort of generalized population-based ideas don't resonate with somebody who has to make a decision about their own organization or their own community. and how to sort of straddle that tension, particularly around these things that we're dealing with, social determinants of health in our ED, which is, you know, at the end of the day, we are all emergency physicians, and we're thinking about social determinants at our local level. Is going to be a challenge, and it's probably important to think about.
Saivash, and then I think we have to wrap it up.
So I was hearing what Hemel asked about what are we doing that's working, hearing people talk about pragmatism, offloading, some of the work that may be involved in actually creating interventions. I was thinking about, I think Harrison said this at a talk that we did a few months ago, sort of as a joke, but I wanted to put it out there as a thought experiment of, what if, just like we call a code STEMI or code sepsis, you could call a code social, right? And so you can create this idealized team of people who would address, the issues that we're talking about here. And so, really thinking about what would that team look like, and what are the practical issues that you can address in that moment. And I think using that as sort of a baseline to say, this is where we're at right now, and then thinking about how that team evolves over time might be a good way to, create some real interventions that we might be able to do at the bedside or be able to do on a daily basis.
That's actually a great note to close on. So this was our introductory paper. The paper was meant to lay the groundwork for a couple of case studies that will come next. I want to remind people that the case studies are just that. They are not the totality of social emergency medicine. There are a couple of specific areas within social emergency medicine that we thought might stimulate conversation, might stimulate thought about other areas, and also about how to dig deeper into these specific areas. So housing and violence do not comprise the universe of social emergency medicine, but are examples of how to initiate a conversation about realms within social emergency medicine. And we'll take one of those case studies up after a brief break.